So I'm excited to introduce Dr. Joanna Katzman, who is a neurologist and professor at the University of New Mexico with secondary appointments in the departments of psychiatry and behavioral sciences, as well as the College of Nursing and Population Health. She's director of Project ECHO's public health programs and director emeritus of the UNM Pain Center. Among the many reasons we thought that Dr. Katzman would be amazing to come speak to us is because she has led programs to teach healthcare providers about climate change and health. So you have the full bio in your invitation, but with that, I will turn it over to Dr. Katzman. Thank you so much for being here.
Thank you, Daniel, so much. And thanks, Kai, and I know Dr. Dubrow and Dr. Sherman aren't here, but thank them for having me too, and thank you all. And I'd like to try to make this as informal as possible. So if you do have any burning questions during the talk, please feel free to, raise your hand or ask. And I'm hoping that we have time at the end as well. So I'm a neurologist, and my practice has been in pain management for decades, but I got into public health education about 18 years ago at Project ECHO. And I want to tell you a little bit about public health education, which you all know very well. Public health, that's the program you're in. But a little bit about public health education and public health telementoring, and a little bit about Project ECHO before we begin my talk on climate change and climate change education, so that you can understand kind of how my work in climate change education really works using the Project ECHO network. So the talk today is when climate change shows up in the exam room. And as you know, global warming has been happening for decades, since the time of the Industrial Revolution. Really, we've been heating up, and clinicians and all health professionals really could do a better job of talking to their patients and their clients about how the heat and the air and how the climate really is changing and how they can improve their health. I don't have any disclosures or conflicts of interest, and how I'd like you to kind of leave this talk with is to learn about the benefits of ECHO telementoring, to better understand how climate change and the human health program works, to illustrate that health professionals and public health professionals such as yourselves are the most trusted messengers for patients and community members regarding climate change, to demonstrate some communication skills, and just a few, about climate change and extreme weather events, and to show some evaluation results from our program, from the Climate Change and Human Health ECHO program. So we know that there are many global public health threats. This is from the World Health Organization from 2024. We know that the climate crisis and environmental sustainability is probably one of the biggest threats, the most important threats to humanity. But we know things like antimicrobial resistance, infectious diseases, and global health security is certainly huge. The whole umbrella of non-communicable diseases such as cardiac diseases, diabetes, cerebrovascular diseases, and health disparities is also large. You know that mental health, substance use disorder and addiction, and reproductive and sexual health equity are also large. But I'm pointing this out because the climate crisis and environmental sustainability remain at the top of the list. We also know that the global temperature continues to go up and up. This is a picture where I have lived for the past 29 years. It's the Rio Grande Valley. This is a picture right next to my house in Albuquerque, New Mexico. I could show you a picture of, this is at the end of the summer, and I can show you a picture from 20 years ago, which I won't, but the river was kind of nice and plump, nice and full. And it is true that the government, that the New Mexico legislature can decide whether they want to, you know, pull in water from the big lakes in northern New Mexico. And even when they do that nowadays, the river runs very dry because of the extreme heat and the extreme drought. This is from the CDC, and there's some, and there's been many different organizations. The CDC has done this, the Environmental Defense Fund has done this. You have seen many different types of composite vulnerability indices, looking at neighborhoods and jurisdictions that are most at risk for climate change. But the top chart looks at a jurisdiction of composite vulnerability. And what makes this up looks at percent of population below poverty level, older people, 65 and older, people experiencing heat exposure, people not able to get to the hospital. That's the middle, the green graph below in the center. Below left is patients on dialysis, meaning they already have renal insufficiency, might not have been exposed to the next heat event, which makes them even more susceptible to heat-related renal insufficiency, and a percent impervious surface temperature. And so the top is the composite vulnerability index. So this, a lot of organizations, big ones, the NIH combined with the CDC devised a composite vulnerability index most recently. I'm going to now take you on a tour. I'm going to stop from talking about climate and take you on a brief 5-minute tour about what is Project ECHO and Project ECHO telementoring, so I can better share with you what I've been doing with the climate change and human health ECHO. So what is Project ECHO? Project ECHO is it's a project based out of the University of New Mexico School of Medicine to educate clinicians, public health practitioners, first responders in rural and underserved areas around the United States and globally. And we know that there are almost 2 million people dying of tuberculosis throughout the globe. We also know that over 75 people in Kansas have died from TB just in the past 2 months, right in our own neck of the woods. It's certainly close to me in New Mexico, where I'm transitioning from moving from New Mexico to Connecticut. We also know that in Africa, millions of people are dying from respiratory illness. Almost 1 million people are dying from diarrheal diseases, and many people, many children specifically, are dying from before their first birthday, and vaccinations are an important way to prevent this. So what does the ECHO model do? Well, it uses technology to leverage scarce resources. We share best practices to reduce disparities. The thing about the ECHO model is it almost always combines evidence-based didactics with case-based learning. You try in most sessions to use a case, whether it's a patient-related case, an educational case, some kind of case associated with our program, and we evaluate outcomes. So an ECHO Hub team is comprised of subject matter experts. It can be a team of a public health provider, a nurse, a social worker, a statistician. It can be in one single room where we are now, or it can be a virtual room. And then we share the knowledge to participants that can be spread out, or they can be localized in a certain jurisdiction. Most of the knowledge is bidirectional, meaning we're learning from our participants and they're learning from us, and that's called knowledge networks and learning loops. And we collect data all the time. This is what it used to look like before COVID, where we were in one room and this is a hepatitis C clinic where the larger picture is a hepatologist in the middle, Dr. Aurora, who started Project ECHO. He's a hepatologist, there's an infectious disease doctor, there's a nurse case manager, and a psychiatrist. And all around the sides are different clinics throughout New Mexico in very rural places, 4 or 5 hours from Dr. Aurora, from the university clinic in Albuquerque. So what are the benefits to health professionals? All the ECHOs provide no-cost CMEs. There's a mix of work and learning. These isolated clinicians and health professionals find that they have less burnout, increased resilience. They want to get back onto the ECHO the following week. There's access for a curbside consultation. They tend to want to stay in their practice. Very often, having a consult with the hepatologist or coming onto the climate change ECHO, for instance, is something that brings them joy. And what we've seen in a number of articles is there's a reduced carbon footprint. These doctors don't have to go to fly thousands of miles for their CME learning, right? Take an airplane, take a car to the airport. The patients don't have to drive 4 and 5 hours to see their doctor, their specialist on a routine basis. They can stay at work. They don't have to leave work for a couple of days to get to the only safety net hospital. So this is what it looks like now. This is actually an ECHO going on in Namibia in HIV, and all the clinicians and public health practitioners are on the line. So this is ECHO versus telemedicine. The top row, the top row is what an ECHO looks like. The experts on the far left are the hub team, interdisciplinary group of the hub team, sharing their expertise to the different practitioners, groups of practitioners, who then go on and teach their colleagues, but primarily teach their, learn from one another, and then go on and change their practice, improve their communication skills, and then go on and treat their patients more effectively. And so there's a real capacity building effort that's going on from ECHO. Traditional telemedicine is just serves a different purpose, but it's more one-to-one. Traditional telemedicine has benefits all over the world when doctors can't get to patients, when there's a more remote barrier. It's very good for things like psychiatry. It's very good. It was extremely beneficial in the days of COVID. This is just a different visual for Project ECHO and how it increases capacity and force multiplication. I'm not going to harp on this, but these are just some benefits of the ECHO model in terms of preventing untreated disease and reducing variations of care, because all of the people on the ECHO network, they hear the same thing. And so it kind of reduces that bell-shaped curve. So what kinds of topics, what kinds of subjects are really good for the ECHO model? Well, things that are common. So think about things like climate change, extreme heat, air pollution, extreme weather events. Management is complex, can be complex at times. Evolving treatments and medicines, high societal impact, serious outcomes if disease or the condition is, or the situation is unmanaged, and improved outcomes. ECHO has adopted many outcomes, many topics in over 120 countries. And climate change and human health, we started in 2021 after I took the Yale certificate course, I'm proud to say, with many amazing speakers and peers who I continue to stay in touch with. So then after taking the 6-month course, I thought, oh my gosh, I could use Project Echo to train others after this course. So just in New Mexico, we have 65 different ECHO programs. Here are the ECHO participants with many, many different topics around the country. Here are the counties, the rural and urban counties where we have ECHO attendees. The VA has over 80 different topics that they run. VA Scan Echo, SCAN stands for Specialty Care Access Network. And here are the global hubs and super hubs. I'm going to, in the interest of time, I'm going to tell you that how ECHO really got supercharged was that Dr. Aurora, who founded ECHO, he did a head-to-head study and he taught doctors in rural and underserved communities in New Mexico how to take care of their patients. This was back in 2011. It was funded by, I think, AHRQ. How to take care of their patients. This was before the newer meds, so it was really difficult to take care of patients with hepatitis C. He met with them weekly and he gave them confidence and knowledge, and he would discuss about 8 to 10 patients with them every Wednesday afternoon from 3 to 5. And this is way before Zoom or Microsoft Teams, or he had a Polycom network set up. It was very kind of archaic. He had a nurse practitioner and a psychiatrist and an infectious disease doctor on the line. And he compared that with usual treatment, with patients coming in to see him on a monthly basis. And some had to wait months to get into the clinic because he was the only GI hepatologist in the state. And the results of this 2 to 3 year study were that the patients who were being taken care of by community PAs and physicians and nurse practitioners in their own locations, the patients that felt like they were taken care of in a more culturally sensitive location, but being consulted on by Dr. Aurora on a weekly basis, those patients actually did better than the patients that had to drive 4 and 5 hours to the specialty care hospital at the university. They did better in terms of morbidity and mortality, and was published in New England Journal of Medicine, and it's been replicated now 4 or 5 times. I did it because my original work has been in opioids and pain. I worked with the DoD for many years, and we studied opiate management with the Army and the Navy, and we looked at teaching doctors if we can train them on opiate and pain management, if we could have doctors, if patients would reduce their opiate, if the doctors could reduce their opiate prescribing, obviously if that was what the patient needed. And sure enough, if you can see on these 2 graphs, the graph on the graph A shows that the doctors who came onto the ECHO network had a significant reduction in opiate prescribing per patient per year. And graph B had a more significant reduction in percent change in the amount of opiate, the morphine milligram equivalent, if they came onto the ECHO network as compared to not joining and learning best practices. This is similar to buprenorphine prescribing for substance use disorder. So let's now get on to the climate change and human health ECHO. My goal for this program back in 2021 was to increase provider knowledge and communication skills, because I really believe that clinicians and public health professionals really could benefit from learning how to talk to their patients and their community members more effectively about climate change. That climate change is really happening in the exam room and in the community. So I made a cold call. I took the Yale Climate Change Certificate course and I thought I can do this. I didn't know anyone in the climate change world, and I called the head of climate change education at NOAA, and David Herring picked up the phone, literally picked up the phone. He said, David Herring at NOAA, and I almost fell to the ground. And he said, we had about a 45-minute conversation, and I was just so struck by how humble and genuinely nice he was. And he talked about climate change education, and he told me about the Interagency Council on Climate Change Education, the CHIG, and that he worked closely with someone named Paul Schramm from CDC and John Balbus, who was at the NIH at the time, and how he was going to help me create this eight-week course on best practices for climate change and health. And so over the next 6 months, we put together objectives for a best practices 8-week course. And that's what we did. So we created in February of 2021, we took 6 months and we got approval from with John Balbus and Paul Schramm and David Herring, working with the CHIG, this US Global Change Research Program, to put on this 8-week course, 1 hour per week, virtual, open to all health professionals. They would get CME and CEUs for no cost. And we created simulated cases. So we could show the participants how to talk to patients about climate change, including didactics at every session. So from there, that I'll tell you a little bit about the evaluation of that course, because we really wanted to evaluate that program. From there, it was a highly successful course. But from there, we decided we want to go on, we want to replicate that course again, but we don't want to do it right away. We went on and we had theme months in extreme heat, mental health and climate change, environmental stewardship, for which we've had a second environmental stewardship month as a theme month for 6 weeks. We did a program on degraded air quality, emergency preparedness and extreme weather events. We did a whole section on climate tools, environmental impacts, climate impact in indigenous communities, nature-based solutions, practical applications, and we developed really close partners with the CDC, continued with close partnerships with NOAA, and we developed local partners, with NGO partners such as Environmental Defense Fund, and then local partners such as our New Mexico Department of Health, our local medical consortium partners, our local 350 partners, and so on. So we developed a lot of partners moving forward. During the first 8 weeks of that 8-week pilot, want to give you a sense of what we do, just so I can change this up. Hoping this works. Bandwidth is okay. I didn't check it in the room here. Let's just try it out.
You guys able to see my screen now?
Yes, we can, David.
See this okay?
Okay, I'll just bump it up maybe a couple of clicks in resolution.
David Herring.
And this is what the PDF looks like that I have shared. And so you should have a copy of it. And these links are all active. So you should be able to click on them straight away and go into the tools. So I've ranked them approximately in order of from least to most complexity. So I'm introducing you to 10 tools. They're sort of parsed into tools for beginners at the upfront, and then tools for intermediate and more advanced users. And under each is a little bit of an interpretation as to what is the purpose of the tool and why you might use it. So in the NOAAclimate.gov website, we have the global climate dashboard. So you could click that link and jump straight in there. I've got the website open here. And if you go to climate.gov and then you scroll down, you can see that right there on the front page, we have the global climate dashboard. And you can select, and I'm going to encourage you to, over on the side, if you want to open another tab or your own browser window, I'll encourage you to do so. And I'll try to go slowly enough that you can sort of follow along and watch what I do and then follow along. But, here we have indicators of both climate change and natural variability. So if I toggle over to natural variability, you can see that there are these natural oscillating patterns in the climate system. I like to say El Nino has an extended family. And so you can also, we track and we give a data-driven readout on variability patterns as well as indicators of climate change. So if you select an indicator, I'll start here at the top left. This is the NOAA Annual Greenhouse Gas Index, or the AGGI. And we've taken sort of a layered approach. I'll just say, first of all, share at this as well. And if I step down to a landing page, I get a higher level readout. I can grab this down and use it in a PowerPoint. If I want to learn more, I can sort of scroll backwards and forwards, and then I can just kind of walking you through why does this matter? How are today's values compared to, say, over historical periods, where you can go to read and learn more.
Okay, so I just wanted to give you a nugget of what he did here. He's come back several times, and he has gotten more specific to different tools that you can actually use with patients. So different heat tools, different air quality tools. If we've had a real big fire, not the Palisades fire, but for instance, when we had the Paradise fire in LA, or when we've had the heat, the severe heat in Washington, state of Washington, he was able to come back and show participants how you can really talk to patients about using tools on cell phones, so patients can learn how to use those tools. But this was more teaching kind of clinicians how they can actually understand what's going on themselves.
Guys able to see my,
Just trying to. Okay, so just breaking this up a little bit. So again, increasing knowledge, increasing confidence or self-efficacy, and increasing communication. Something at every session that we want to really ensure is that we're teaching health professionals, public health professionals, educators, that we're getting across communication skills. Part of it is just knowledge transfer, but part of it is that we have to do it in a way that we're not offending the patient. So really getting across, meeting the patient where they are, finding out kind of how much do you know? Are you well versed in climate change? Do you want to hear this today? Is this something that's related to the visit? Would it be better if we talk about this next time? Do you have time to talk? Is this meaningful to you? Meeting the patient where they are. Telling stories, we find, is one of the most effective way to get something across to a patient. It can be to a patient if they're having a hard way to just hearing the facts. I would do, if you were in my shoes, I would do it this way, or it sounds like, I'll tell you about a case in a minute, by the way, but this reminds me of X, or it reminds me of a time when I did it like that, or telling stories to a patient can be very, very helpful. And then, yeah, providing them with as much education, whether it's verbal, whether it's giving them handouts, can be extremely helpful. So multiple different ways, multiple different visits can be optimal. And the biggest thing that you want to do is have them come back. You really don't want anything as off-putting as them to say, you know, adios. I'm not coming back. I don't believe in this, and you know, I'm not coming back. You really want to kind of engage. So one of our early stories was a man by the name of Joe Bender. Joe was a 45-year-old man. He worked for the US Public Health, not Public Health Service. I'm involved with too much federal stuff going on, but US Postal Service for over 20 years after leaving the Navy. And he walks approximately 4 to 6 hours each day carrying mail. And this is in Las Cruces, New Mexico, which, by the way, is not known as a huge urban heat island, but it definitely is an urban heat island if you dig deep. He's been doing this for the last 20 years, and in the summer, Las Cruces is over 100 degrees Fahrenheit, and this is not even counting what the heat index might be if there is any humidity. He carries mail in the direct sun with little shade. And he comes into the clinic today because he's feeling dizzy and nauseous. He vomited once and was brought in by his concerned daughter after a long 8-hour shift. And this is not the first time that he's dealt with a situation like this. Do any of you think you might know what's going on with him?
Like he's probably having like a heat emergency, something along the lines of like heat exhaustion or heat stroke, depending on like how far it's progressed.
Totally, yeah. And can you think of what things might be complicating? What things might be complicating his medical history? It's not in this little history of the present illness, but well, he's not using any so there are, like, if he was dehydrated to begin with, or if he had drinking alcohol, he was on certain medicines, things like that to make him even more susceptible. But that's exactly right. So he's a real setup for something bad to happen, right? We don't want him to get to the stage of like getting a heat stroke. That's exactly right. So
walking my route in the sun, and I don't know, it feels like it's got to be 110 outside today, and
so let me just,
when I got home, my daughter said I was just acting confused and out of it, so she insisted I come in.
Right. Is she in the waiting room or parking the car? It would be great to be able to talk to her too.
Yeah, she should be there, I think.
Gotcha. Tell me a little bit more about what you do.
Why, I've been working for the USPS now for, I don't know, like 20 years, and I've got my my route that I do, and yeah, I don't know, just today, I don't know, I just felt out of it, kind of got dizzy and nauseous, and yeah, that's just kind of where I've been at.
Gotcha. You seem a little bit cold, we drew your blood for, some important labs that we wanted to get. But I see the nurse is right here giving, can get you a warm blanket. Your temperature was a little bit elevated and, not uncommon for you to get chilled. So this warm blanket should help you.
Yeah, I am feeling a little chilly, which feels, yeah, it's a
Right,
little odd after being
Right.
so hot, but
right, absolutely. Is it okay if I call you Joe?
yeah.
Can you try hitting the play button again?
Here.
Yeah.
Right. Tell me a little bit about that nausea and vomiting and dizziness. Are you still having those symptoms right now?
Yeah, I'm feeling dizzy, and stomach just feels a little upset. I did end up vomiting, a bit, so feeling that upset stomach still.
Right, right. Joe, have you been sick recently?
Not like an illness or anything, no flu or anything like that.
Mhm.
Just I don't know. I'm just feeling out of it today.
Right,
Well, let me just tell you all, this one's a little slow, but he ended up, Joe Bender ended up going on a bender the night before, which he probably shouldn't have, but that set him up for significant dehydration that next day. Turns out he had a history of having had experienced kind of a near heat stroke or heat exhaustion a year prior. He's in the sun daily in the summer months in Las Cruces and is a real setup for, at risk for having heat stroke. Luckily, the labs showed that his kidneys were not compromised. Very soon at the beginning, after he got with minutes after getting the blanket, because his temperature was elevated. That's why he was getting chills. You get chills when you're having rigors and elevated temperature. He got IV fluids. It was hard to kind of portray that on the simulation, but he got a bag of IV fluids. His labs were all okay, so luckily his kidneys weren't, going into like a rhabdomyolysis. But he wasn't on any psychiatric meds, which could also interfere with heat, can also interfere with psychiatric medication function. So his daughter ends up coming in and we talked about some strategies in the future, like talking to his supervisor, and I offered to talk to his supervisor about changing his schedule. Can he work very early in the morning so he's avoiding the middle of the day? Can he use a wide brim hat? Does he have to work by walking? We talked to him about that. Can he use a postal car as long as it's electric, right? And there's a lot, and everyone in the chat on the Zoom is adding all their, suggestions. Can he go to cooling stations? Gotta have those. Can he have at least a couple of bottles of water with him or Gatorade, electrolyte solutions? So we talk about a lot of mitigations strategies, checking the color of his urine and make sure that he's not getting dehydrated. So that's this case. And I'll move on to that, but I just wanted you to see a typical case. Okay, and so I talked about that case and how we strategize that. But in kind of throughout the case, we're breaking and we're talking to the participants of the echo. And you can see at the bottom of New Mexico, that white dot is Las Cruces, as kind of an urban heat island. So going back now to our original ECHO series, the 8-week series, this is what we developed with, the CHIG, the Interagency Council on Climate Change. These are the 8 weeks that we developed. It covers the science of climate change, connecting climate change and human health outcomes, extreme heat. Week 4 is degraded air quality. Week 5 was water and vector-borne illness. Week 6 was mental health. Week 7, extreme weather events and disaster preparedness. And week 8 was climate change communication. And we had cases in 5 of the 8 weeks. And you saw some of the cases. You saw a couple of the cases that we had during these sessions. And I wanted to show you during these 8 weeks, these were the presentation of these cases. These were the opening questions from each of the patients and our communication strategies. The third case I'm going to show you, the third and last case, is this hurricane and waterborne illness.
All right, so I get to read the presentation. So Kevin Boyd is a 51-year-old male and member of the Choctaw Nation from Pearl River, Mississippi. He suffers from heart and vascular disease, insulin-dependent diabetes, and low back pain. While rushing to protect his family from the aftermath of a Category 5 hurricane, Kevin left his house to get food from any available convenience stores. In his frantic search, he was caught in a dangerous flood for several hours. The water was probably unsanitary, and by the time he was able to free himself and get back home, his basement and first floor had flooded. Kevin moved his wife and 90-year-old father to the upper levels of the home for protection and began to secure the building to the best of his abilities. While rushing to protect the windows, he fell off the ladder and hurt his arm. His wife called for help, and an air ambulance rushed him here to get to the urgent care clinic.
Just gonna move in to see if Mr. Boyd is available for me to see in the urgent care room right now. Mr. Boyd, are you there?
Yeah, I'm here.
Great. Gosh, I vaguely remember seeing you a few years ago. Tell me what's happening.
Well, I just got off a helicopter with the Coast Guard that brought me in because I fell off a ladder and I think I messed my arm up really bad. I'm just trying to lock my house up after the hurricane.
Right. The urgent care's just been inundated with the hurricane victims. I'm so sorry. I see your arm is in, your arm looks terrible right now. Do you have pain anywhere else?
Yeah, my stomach's a big mess too. I've been getting sick and stuff like that. And I think I have the rush or whatever. So yeah, I'm just a big mess right now, actually, to be honest with you. So
Right. So your arm and your stomach, and you fell, right? You fell with your arm? Did you?
Yeah. There were some branches. There were some branches that came through one of the windows and stuff. So I was just trying to, batten everything up. And, I must have been going too fast and I fell off the ladder. So.
Can I call you Kevin, Mr. Boyd? Is that okay? You go by Kevin?
Kevin's fine. Yeah.
Did you hit your head or back? Does anywhere else lose consciousness?
No. And I've got kind of a bad back thing going on too, but I'm fine as far as that goes. And I didn't hit my head. It's just my arm and my guts.
So I'm going to stop there. He's got a 95-year-old father that he left at the house. He's got a mother that's ill and a wife. He did not want to, he ran out of clean water. He kind of like the New Orleans Hurricane Katrina. This was in, I think, Mississippi. He had to leave his house to go look for clean water. He got into the floods. He probably picked up an E. coli, gastrointestinal diarrhea. He got to the urgent care and there I was. And so he had broken his arm along the way, getting out of his house, picked up a diarrheal illness from the waterborne illness, and here I was taking care of him. Meanwhile, his family didn't know where he was. His phone fell into the water and family had gotten earvacked. So that was the case. I just want to move on to show you some valuation of these programs now. I just wanted to show you this about kind of the climate drivers and just that he was probably suffering from kind of the waterborne illness from the flooding, his contaminated water. We got him on some antibiotics. We got his arm wrapped up and he did not have any head injury. So in our first climate change echo, we had 625 participants. Many attended 3 or more sessions. Many attended up to 8 sessions, 42 participants. But as you can see, a vast majority attended 3, 4, 5, 6, 7 attendances. For whatever reason, Project Echo, female participants outnumber male participants. And I don't know, education in general, my programs have been significantly more attended by female participants than male. Even I produce a violence prevention echo and female participants seem more wanting to come on programs. I'd be interested in your educational programs as well. Race and ethnicity seem to be predominantly 53% white, 14% Hispanic, 6% Asian Pacific Islander, and the rest seem were about 5% Black and about 5% American Indian. We had a good mix of doctors and nurse practitioners and 11% public health professionals. They came from all over the country, 45 states, and actually 25 countries outside of the US. This might be a little hard for you to read up on the board, but I can share it for you here. When asked in the post-session survey how well, so this was after the 8 weeks, how well were the stated objective met? The vast majority answered either very good or excellent. How well did the session deliver balanced, objective, and evidence-based content? Over 90% answered very good or excellent. Were there opportunities to answer questions? Again, the vast majority answered very good or excellent. Were there opportunities to improve education techniques? There were 104 responses and 38 people said yes. We also, starting with week 4, we didn't get to this until week 4, we started doing Zoom polls, asking people in real time during the program in a live format. We asked people about their confidence in the session. And the vast majority either agreed or strongly agreed that their session improved their confidence in discussing or communicating the relationship with the topic at hand. So week 4 was about degraded air quality. So for instance, 137 people during week 4 answered that they could agree or strongly agree that today's session increased their confidence in discussing the relationship between air quality and health with others. And we did this for the remainder of the 8 weeks. We also, unrelated to the first 8-week session, I also wanted to let you know we did put on those other theme series, whether it was extreme weather events, practical applications, but we also put on the mental health series as well. And for the interest of time, I'll skip over this other simulation. I want to show you something that maybe it comes later. What I wanted to show you that I have in another version of the PowerPoint was in that first climate responder series. I don't have it, but it's published in an article in the Journal of Primary Care and Community Health. We looked at 3 months post, and we got a significant stay in communication 3 months post, meaning that people who responded pre, post, and post 6 months are continuing to talk to their patients even after 3 months in that initial series. We replicated that initial 8-week series 1 year later and called it the Climate Responder Echo. And this series we collaborated with Columbia's climate consortium. And in this series, we had 804 participants. The first series, remember, we had 625. This series, we had 804 participants, 610 from the US. And because we collaborated with Columbia, we had a lot of international participants because of their consortium being so highly international. We had 25%, in addition to physicians, we had 25% nurses, 17% physicians, and slightly less public health professionals. We evaluated participants pre-post, and unlike the first one where we evaluated participants 3 months and found continued success at 3 months, we evaluated people at 6 months. And here I wanted to show you just a little bit about the demographics. There were 415 women, again, significantly more women, 165 men, again, this being a voluntary program we could control for any of the people who voluntarily come. You see the race and ethnicity and profession. We had the locations. And here what I want to show you is the frequency at pre-survey, post-survey, and 6 months. So if you look at the far right and you see frequently, how many people are frequently talking to their patients or community members about climate change. These are linked responses. So even though there were a lot of people that attended at least once, 610, it's not easy to get linked participants that answer the survey pre, post, and at 6 months. 6 months is a long time from before they began the participation. So the linked participants, the 67, all increased even after 6 months. So 6 months later, the people that answered, although they are a self-selected group, are increasing their frequency in talking to patients. In addition, the people that did answer at 6 months said they were a little confident, moderately confident, or very confident that they were going to go on to teach a course, create a course, or begin a course on a climate change. Just because I work a lot with Jody Sherman, I just wanted to let you know that she was also part and parcel of creating a healthcare sustainability series in 2023 that was very successful. This was the course that we did. And we're going to wrap up right now. This was just the results. And the last thing that I want to show you is that these are just the results of it. Just want to show you, maybe I can get to the last slide, which I don't know if I can. It's kind of thinky. We're having a monthly series right now going on at ECHO. that's talking about all the different health-related causes of climate change. And Wednesday, there'll be a talk. Mental health causes of climate change. That's my last slide. But anyway, I'll open it up for questions.
For the sake of time, we could take one quick question. I'll quickly ask, are there any strategies to potentially increase the participation of nurses? I know that physicians are highly trusted, but even more highly trusted are nurses.
Yeah, I would say if doctors are busy, I would actually venture to say nurses are even more busy than doctors. And I think COVID, the burnout, Daniel, from COVID has even been harder for nurses. Yeah, I would certainly like to get more nurses involved. They sit at the bedside and have such an opportunity to talk to patients. I would love to talk to you more about that, and Kai. Yeah.
Thank you so much. So for folks, there's lunch after this with Dr. Katzman in room 4, in room 710. So please take advantage of more time with Dr. Katzman.
This is the last slide. If you have an opportunity and you want to come to a psychological impacts of climate change talk on Wednesday, you can take a photo of that.
And next week we have our last seminar with Jane Gilbert, who's the Chief Heat Officer of Miami-Dade County. So look forward to seeing you all next week.
Thank you.